Yeah, it's another exercise, right? It's another tool to put in your belt there, right? All right, so just to make sure that everyone understands, we are now changing gears. We are stopping talking about PNF. We are stopping talking about Therex, and we are going to do one of the last 2 lectures really on kines, because we have this special tests left, and that's it. There's no more lectures. That's all review from there. So we're going to talk about today's the lumbar pelvic girdle, and then we're going to talk about special tests. And that's it. There's nothing else I really need to teach you in kinesiology. I can teach you about the TMJ, but really that's not what we're going to do. So we're going to change gears. I'm going to stress this again. We are changing gears and now moving into kines, and we should finish a little bit early. I know you'll be sad about that. We should finish early and get you out of here early, because there's not many slides in this lecture. All right. Oh, I got a message ready. Okay. So again, like I said, we're changing gears, going into kines here. I used to have all the PowerPoints be the same color. That's why I now purposely changed the colors of them so that kines is one color, Therex is another, but they're all uniform. That way you can tell. So the lumbar spine and the pelvic girdle is what we're going to talk about now. We already talked about the cervical, and we talked about the thoracic, and we talked a little bit about the lumbar because you can't really escape it, right? We're going to start kind of in the pelvis itself, and we're going to do our basic anatomy review like we've been doing, right? So structure of the pelvis is made up of 4 primary bones. Our sacrum, right, which is kind of that bottom part of our spinal column, right? Our coccyx, and then our 2 os coxae bones, right? Or our 2 true kind of hip bones. Those are our structures of the hips or the pelvis, right? There are 4 primary joints. There are 2 sacroiliac joints, where the sacrum and the ilium articulate together. There is our pubis symphysis in the middle of our pelvis, right? And then there is this lumbosacral joint here, and that's where the lumbar bodies end and the sacrum begins. So that's it for the bony kind part. We're going to talk more about the bones here. What is the function of the pelvis? Well, the main part is support weight of the body and receive our ground forces. It's also going to support and protect our pelvic viscera, so our bladder, and also in some components, right? Whether you're female, it's protecting some of your reproductive organs. Yeah, L5S1 would be our lumbosacral joint. Yes, that is correct, Anthony. If you're a man, is still some of your reproductive organs within the pelvis? Yes, right? Because you have tubes that pass through the pelvis as well that carry, the necessary reproductive fluids in order to have kids, right? Yes, there are. But most of the reproductive organs of the males is outside the human body. Why is it? Why are the testes outside of the human body?
It has to do with the temperature. Good.
Yeah, right. It has to do with temperature. The testes are slightly cooler than body temperature, right? Even though if you could argue that they may not feel like that. They are slightly cooler than body temperature. The idea is that sperm exists at a slightly cooler temperature than, it's normally the 98.6 or 37 degrees of the body, right? Which then also, like, to me, like when I think about that, because I've taught reproductive health before, when I think about that, it amazes me that we ever actually conceive children. Because when you think about it, if the sperm exists best in lower temperature environments, slightly lower, not totally lower, right? And then in order to impregnate a woman, those sperm have to go back inside the body. That's why there are a million of them, because a lot of those swimmers are going to die. That's kind of what happens, right? And whether it's the hostile environment of the female body, which it is hostile to sperm, or it's just temperature difference, right? Or maybe the man has problems and he does the sperm aren't motile. They're not able to move. There's all kinds of reasons for that, right? It makes sense, though, that the female genitalia are primarily inside the pelvis because, like, for those of you that are mothers, just imagine if you had to carry baby outside of your pelvis. Like, that would not have been fun, right? Walking around with like a sack of baby hanging down between your legs. First of all, that would have looked really weird. And second of all, that would not have been bueno, right? And then the kids got temperature differential and that wouldn't work either. So these are the uncomfortable topics we're going to discuss with Mr. McKeever. Just wait till we talk about sexual reproductive health and stuff like that in 5th semester. That'll make you guys really uncomfortable. It also provides muscle attachments and makes up the bony portion of the birth canal, right? And again, pelvises differ between males and females. We know that. This is known. So within the pelvis, we have these two terms. And I don't know if Dr. Johnson mentions this in anatomy. Did he mention the true and the false pelvis in anatomy?
Yes.
Okay, good. So he did. I asked him to add that. He wasn't adding that before, so we added that. So the false pelvis is kind of everything outside of the true pelvis, right? It's the greater or a major pelvis, right? It's the bony area between the iliac crest, superior to the pelvic inlet, and there are no organs there. That is more of our bony protective area, right? And then we have the true pelvis, which is between the pelvic inlet and the pelvic outlet, and this is where the pelvic cavity is made. This contains parts of your GI tract, your urinary tract, and some reproductive organs, including the birth canal in females, right? And usually the way I kind of remember is, I like this drawing showing it, is that the true pelvis kind of goes from your S1 down to the tip of your coccyx, and the false pelvis is kind of everything else. You mentioned false ribs. So the way to remember this, at least for your boards, is just remember that the true pelvis falls between S1 and the end of your coccyx. That's the easiest way to remember it. The other thing, what would be a board question about this? The board question would ask you, do the pelvic organs lie in the true or the false pelvis, right? You know that they lies in the true pelvis. I hate false pelvises. They tell lies. But wait a minute. I just thought of this. The false pelvis can't tell lies. Shakira proved us this because her hips don't lie. Anyway, moving on. Okay, I made Raquel laugh. I've made Raquel laugh. I've had my day. So with the sacroiliac joint, so where the sacrum and the ilium join together, it is a synovial joint and it is non-axial. So what does non-axial mean?
Doesn't move.
Yeah, it doesn't move. Now, I don't know if any of you have ever been in the clinic where you hear people say, we're going to do sacroiliac mobilizations. I mean, theoretically, there's probably a technique to do it, but I'd really like to see the research on actually mobilizing that area. But what does occur around the sacroiliac joint is this term called nutation and counternutation. So in nutation, the sacropromontory moves forward and moves anteriorly, inferiorly. Counternutation, the sacropromontory moves posteriorly and superiorly. Where did my picture go for that? Oh no, my picture's off that. So what this is saying is that sacroprominence, right, that kind of top part of that sacrum, when it tilts, over there drawing, right? So here's my sacropromontory, right? Sacrum, coccyx. When that sacropromontory tilts anteriorly and inferiorly, that is nutation. That's going to go partially a little bit with anterior pelvic tilt, right? But you can also tilt the pelvis without doing true pelvic tilts, which we're not going to really get into that theory right now. Counternutation, the sacropromontory moves backwards, and technically it's moving superiorly, so it kind of goes like that. That is a really good drawing of the pelvis, Mr. McKeever. Thank you, Mr. McKeever. So the main thing you need to know about this, you don't need to know how to do that on a patient, nutation and counter nutation. Just understand the definitions. That's it for that. So let's talk about the bones because that'll help make that more sense. We have our base, right? It's all about the base, no treble, right? We have the base, right, of the sacrum. We have our promontory. What does promontory mean?
Is it like a prominence? It sticks out?
Yeah, it's basically a hill that sticks out, right? There's an area in Gettysburg called Promontory Ridge, which is this ridge that kind of sticks out and looks over the battlefield, right? So that's the way I always thought about this when I was thinking about it. So promontory is kind of like a ridge looking out over things, right? That's kind of, if you look at this, it almost looks like it's a cliff looking out over things, doesn't it? You can see a guy standing here, he's hanging out. He's looking over the Grand Canyon of the pelvic surface. No? Okay, fine. We have our superior articular processes, right? Superior articular processes are going to articulate with that last lumbar vertebrae. We have our ala. What does ala mean?
Wing?
Yeah. Ala is given to you by Red Bull. It's the wings. Good, right? We have our ala, which are wings. We have our foramina, or our foramen, right? The holes. Pew, 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 pew. We have our auricular surface. And I mentioned this to Dr. Johnson. I don't know if he ever kind of covered this, but what does auricular mean?
Having to do with hearing?
Yeah, right. So if I was to take and block off all the rest of this pelvis and you looked at the auricular surface, it looks like an ear. Right, so the auricular surface I like to think of as the ear of the sacrum. And then we have the pelvic surface, right, which is kind of forming that pelvic inlet area, right? Good. That's that bony review. Yay. Then we got the two other bones kind of here. We have the ilium and the ischium. The ilium's the superior part. The ischium's kind of the bottom part. With the ilium, we have our iliac tuberosity, or ilia tuberosity, depending upon what book you're looking at. We also have an auricular surface of the ilium. Gee, I wonder what that's going to articulate with. I wish I could have told that from, the other one, right? Makes sense. You have an auricular surface on both. You have the iliac crest, which is kind of that top part of your hip bone, right? You have a PSIS, a PIIS, an ASIS, and an AIIS. And the one thing that always helps me kind of identify if I'm looking at a right or a left pelvis to me is the greater sciatic notch. So I find my greater sciatic notch, and then I find my acetabulum, and that tells me if I've got a right or a left pelvis. The ischium is kind of the back bottom surface, right? So typically when we're looking at ischium, we usually look kind of like right there. The ischium has the body, which is most of it, right? We have our rami, right? Because we have a superior rami and an inferior rami, which basically means curved bones, right? We have our lesser sciatic notch, which is just below the greater sciatic notch. We have the spine, right? And then more importantly, we have this big thing called the ischial tuberosity. The other term for that ischial tuberosity is what?
Sits bones.
Yeah, sits bones, your butt bone, right? That's the one you sit on all the time. It's your butt bones. And so Brooke says she has a hard time palpating the PSIS. And that's understandable. What I think of, and maybe we can do this when we get back, the PSIS is going to be right where your dimples are if you have dimples in your low back. So when I palpate for my PSIS, I find my lateral side, so that iliac crest, and I follow my iliac crest back until I get just about to where my spine's going to meet up with it. And right there should be 2 points. They're not always as prominent as that ASIS, right? And we can get somebody that's got some pretty prominent ones when we get back to palpation lab and kind of get you to feel a little bit easier. I think I have a little bit easier time doing this from doing massage, because a lot of times PSIS and the ASIS and the ischial tuberosity are areas of tightness. So I'm used to kind of palpating for them, if that makes sense. But if you follow those crests back, you can eventually find them. And usually if you find them, most of the time, they're a little uncomfortable for you. Just because they're usually 2 spots of trigger points, at least for me. When I find those, I don't know about anyone else, but when I find those PSISs, they're kind of tender. Should have no problem finding the ischial tuberosity, though. That's the butt bone. That's what we're sitting on. Some of us have more prominent butt bones. See, okay, good. We also have the pubis. I don't think I actually really talk. Oh, I do talk about the pubis coming up here. Good, okay. All right, here's the fun part about the pelvis. There are a metric ton of ligaments in there, like just too many ligaments. There's the anterior sacroiliac, the interosseous sacroiliac, the short posterior sacroiliac, the long posterior sacroiliac, the sacrotuberous, the sacrospinous, the iliolumbar. Oh my God, ligaments. This looks like the ankle all over again, right? The good news again is they are named for what they are, where they go from and where they go to, and if they're kind of an anterior, posterior, superior, and inferior, right? Anterior sacroiliac ligament. It's going to be on the front side and go from the sacrum to ilium. Interosseous sacroiliac ligament goes between bones. So it's going to go between them and kind of fill that gap that kind of occurs there between the sacrum and the ilium. So there's going to be a little bit of a gap there. So I like to think of those as my gap ligaments. My short posterior and my long posterior are both going to be on my posterior side. And the good news about that one is most of the times the books aren't going to separate them. They're just going to call this the posterior sacroiliac ligament. Sacrotuberous, right, is going to be going from the sacrum to the what, do you think? Sacrotuberous.
Ischial tuberosity.
There you go. Right, from the sacrum to the ischial tuberosity. You got it. And then we have our sacrospinous is going to go from the sacrum to the spine of the ischium. And then we have our iliolumbar. The iliolumbar goes from the top of the ilium, right, from the top of the iliac crest over to the lumbar bones. The good news, again, like I said, is they all kind of name where they go. Now, there are PTs that say, I can mobilize all of these ligaments. And the ones I always love is when they say, I can mobilize these 2 ligaments. Look at where those 2 ligaments are for me. House sway. What are you trying to say there, John? Sorry.
Nothing. It was just a meme.
Oh, okay. I did not. I'm gonna have to look that meme up then. There is only one way you can mobilize these ligaments. What do you think the only way you can mobilize those ligaments is?
Gotta get real personal.
Yeah, you got to get real personal.
Like during intercourse?
Yeah, I mean, technically, yeah, you'd be mobilizing them during intercourse. Yeah, a specific type of intercourse in particular. And let's just say not the typical intercourse, not the traditional intercourse. Oh, Bianca. Oh, man, it's like, I got it. Right. So in order to mobilize those, you have to get a little internal, both on man and female to mobilize it. So I'm like, nope, I'm out on that one. But you theoretically could mobilize them. Kids, little babies, when they're in utero, love to mobilize those ligaments with their feet. Sydney just got it. She's like, okay. We talked about these type of things earlier, and Sydney was out on those. She's like, nope. How is that possible? Oh, okay. I did not know that. I evidently must be lost on my Yeezy stuff. Now we go down to our pubis symphysis, right? We have our superior and inferior pubic ligaments. Makes sense, they're on the top and the bottom. And then we have our pubis, which has our body, our superior ramus, inferior ramus, and our tubercle. Those are all pretty easy on the pubis themselves. The main difference, or the main thing also that we have here, is this kind of interarticular disc in that the pubis symphysis where everything kind of lives there. It's not really thought of a lot, but it does provide some cushioning for the pelvis so that it doesn't just bang against each other. Pelvic girdle motions. We have anterior, opening the drawer, posterior pelvic tilt, closing the drawer. We have lateral tilt, right? And then we've got rotation that occurs when you walk, right? Or sachet, if you're watching one of those, the America's Next Top Model, so I heard, motions, right? So anterior pelvic tilt, posterior pelvic tilt, lateral tilt, and then rotation. We have a little bit of rotation occurs when we walk. We have a little bit of that tilt that occurs when we walk. All of that kind of goes into helping us keep mobile. This is just looking at that diamond again we talked about with the anterior pelvic tilt and posterior pelvic tilt, how those work. The lateral pelvic tilt, there is muscle kind of synergy that works as well again, but the muscle synergy at that point is my abductors and my quadratus lumborum that work together to cause lateral pelvic tilt to occur. Freedom of movement. We talked about the lumbar, thoracic, and cervical already. At the pelvis, sacrum, and coccyx, there's very minimal motion as far as the individual bones go. But as a whole, the whole kind of pelvis moves in order to allow us normal function. If the pelvis didn't anterior and posterior pelvic tilt, lateral tilt, and rotate, when we walked, we would be very robotic and maybe not even walking at all, right? It would look really, just really odd. And this can be seen, especially if you've got somebody that ends up with a pelvic fracture where they have an external fixator and they've got all those rods and stuff sticking out. When they walk, it's more like a hitching than it is walking because that pelvis just doesn't move as smoothly. So pathology, the primary cause of disability in middle-aged working class adults is related to low back pain, right? How many of you guys would say that, yeah, at some point or even right now, you're suffering from low back pain? Right, yeah. And then once you injure your back, what happens? So once you injure it, yeah, it flares up. It gets easier to re-injure, right? This blows my mind. It accounts for $50 billion in healthcare costs annually in the United States. Think about that. Now, how much could we save if maybe we did PT once a year? Do you think we could save some of that? Maybe, I don't know. It's my thought process. Have a lumbar class once a year for every person in the United States. Lumbar spine injuries are also to blame for literally millions of lost work days per year in the United States. I will say that I lost almost 3 weeks, right? Especially learning body mechanics, right? Yeah. I lost like 3 weeks when I worked at Summerlin from a lumbar spine injury, right? And literally, I'm not joking, when it happened, I was sitting watching the Packers versus the Falcons on a Monday night. I'll never forget it. And I went to get up from my couch and I realized that my legs wouldn't work. My back had swollen that bad from the injury I got at work. And I was out of work for about 3 weeks because of it, because I literally just could not even get out of bed. Prevalence of low back pain in the population is close to that of the common cold. That is just crazy to me. So what can happen? Well, we can have scoliosis, kyphosis, and lordosis again occurring, even at the lumbar region. So scoliosis, lateral curves, right? Kyphosis is where we get a hump back. And then lordosis, where we get a sway back, right? Where you get a hump, that hump going forward, kyphosis, hump going backwards. I like to think of kyphosis as the Hunchback of Notre Dame. That's how I remember that one. We talked about spinal stenosis the other day. We talked about herniated discs. We talked about osteoporosis, compression fractures. All of those are just as common in the low back as they are on the upper back. We talk about spondylosis and spondylolisthesis. The interesting thing here about the low back is the compressing forces on it. So let's say you weigh 100 pounds. Let's just make it easy. So you weigh 100 pounds. When you're standing, your discs are receiving 100 pounds of pressure. When you're lying down, they're only getting 25 pounds. They're able to spread back out. When you lean forward and you're standing, that 100 pounds becomes 150 pounds on those discs. When you're seated in a flexed position, so slightly flexed forward, it does reduce it a little bit. You get about 85%. But if you bend forward in a flexed position and lift, it can up to be about 275% of your body weight. That is crazy to me. So it's really easy to screw up those discs just by moving around a little bit. Of the low back, the lumbar region, open packed is midway between flexion and extension. Closed is full extension, just like the rest of the kind of the spine. Capsular patterns.
Mr. McKeever,
Yep.
sorry.
Nope.
Going back to that previous slide, the difference between flexed and bending, or sorry, bending and flexed, wouldn't that be the
Yeah, so
same?
bending, so a flexed position is more when I just kind of have a slight hitch to it.
Oh, got it.
Right.
got it.
Bending is when I'm kind of way over. Does that make sense?
Yes, thank you.
Okay, no problem. That's why, yes, that's why you interrupt me. Just interrupt me at any time because that way I don't go too fast, please. Because that's the way my brain works sometimes. It's way too fast. So with the lumbar spine, equal restrictions of lateral flexion, followed by restrictions of flexion and extension. But here's the interesting thing, and we've talked about this before. Does it really matter to us if the lumbar spine has a capsular pattern to PTAs?
I don't think so.
Why?
Just because, I don't know, I would say that it's just so compact, I guess.
Yeah, we can't. There we go. I got a couple of you said it. I heard a couple of you chime in there too. We can't do the mobs anyway. Right? We can't mobilize the spine. And we know if we've got a capsular pattern, we've got to mobilize the spine. So, and I'm just saying this, and I'm not saying it's not important to know for the patient, but from our perspective, well, we can't do anything about that. That's got to be something the PT deals with, right? For us, we can work on the stretching and strengthening of the lumbar spine, but when it comes to capsular patterns, the PT is like, patient presents with capsular patterns, we're like, here you go, do the mobs. Not my job. Exactly, right? So, although it's important to know for the patient, it's not so important from our treatment perspective. Now, this could change. Like next year, the boards could come out and say, PTs now can do spinal mobs. I don't think it's going to, but it could. And if that changes, great. We change our thinking and say, great, let me crank on this. No, I'm still not going to crank on the spine. I might do grade 1s and 2s, but I'm definitely staying away from 3s and 4s. All right, full range of motion, lumbar flexion, 60 degrees. Lumbar extension past neutral or hyperextension is 25. Oh, that feels really good. And then lateral flexion is about 25 degrees to either side. For functional range of motion, we need about 35 degrees of flexion to sit to stand, right? To get that nose over toes. To put a sock on, we need about 60 degrees, unless we have a sock aid. And then pick up objects from the floor, we need about 60 degrees. With manual muscle testing, there's only 2 tests for lumbar spine. Again, you're not going to have to perform those for any type of testing comp for us, but you may have to perform them in the clinic. It's just flexion and extension. We're not going to test lateral side bending, manual muscle testing. For goniometry, there is a flexion and extension technique. I'm going to show you the book technique again, and then I'm going to show you my technique for it. And then you can just do whatever your PT does for it. Because most of the PTs I've worked with do the same technique I do, where we use just a big goniometer and we don't even break out the bubbles. The one important thing about kind of the low back is this theory of this back school method. And what this is this is literally teaching patients about their back, right? And this is really big in workers' comp and stuff like that, where it provides An understanding of the anatomy, causes of back pain, lifting mechanics, posture, self-care for back pain, exercise, nutrition, ergonomics, everything for it. This is something that's really common, especially in the hospital setting, for maybe once a year for the PT department to host a back school for the whole hospital. And we'll usually have like 5 or 6 sessions during the day where different clinicians come in and teach it. And what we do is we teach the rest of the staff in the hospital how to protect their back, because we are the musculoskeletal experts. So who better to teach them how to protect their back than us, right? That kind of makes sense. This also is happening down at the casinos downtown. They do bring PTs and PTAs in to do kind of worker sessions on protecting the back, you know, and they'll talk to servers or they'll talk to dealers. Trying to think of the one that I saw the biggest kind of strain on the back, and I went to one of these courses with that they held downtown, was the is it roulette? Is that the one with the little ball that you spin around? That's roulette, right?
Yeah.
Yeah. Well, the way they have to kind of bend over to get that ball to move is not very conducive to back health, right? And so teaching them different techniques to adapt their techniques so they don't have to bend over as much helps them out. Blackjack dealers are another one that have really kind of poor posture typically. I guess that goes with poker dealers too, but I don't know. I don't play cards, so whatever. But again, right? And if you ever want to see poor back health, go down to the casinos and look at all of the people sitting gambling. That will give you poor back health and will convince you you're in the right profession. Typically, it's 1 to 2 hour classes, consistent lectures, slides, demonstration, participation for about 4 to 6 weeks. So we'll do a 1 or 2 hour class every week for about 4 to 6 weeks. Teaching about ergonomics, right? Where we do physical capacity assessments, where we check their stress that they're getting on their back in their jobs while they're doing it. Ergonomics, right? Like right now, I have a stand where my laptop's on, because if it was down on my desk, I'd have to kind of look down like this to look at your questions. When it's here, it's still at eye level. I can switch between my 2 screens without having to tilt my head too much. The chair kind of sucks, but. So ergonomics is looking at a quantifiable system of jobs or activities of daily living modification that allows for continued productivity. Is there ergonomics if you're a chef? Are there different ergonomics we could do for somebody that's a chef? Yeah, right? One of the big ones that a lot of chefs don't think about is putting a pressure reducing pad under their feet. Where if they're going to be standing for long periods of time, putting a pad under their feet where they can take some weight off their actual feet. Administered to the patient recovering from back injury is really common before returning to the job. So FCEs are functional capacity evaluations. These are screening tools, again, for the back school method, where we either do pre-employment risk assessment or post-injury risk assessment for low back injuries, where we look at how much weight is lifted by the person, how often are they lifting, right? Thinking back to somebody that works at like a warehouse, the frequency of lifting even small loads can really injure your low back. How far do you have to bend down, right? We ideally don't want to bend down past our hips to pick stuff up. How high do you have to lift the load? How far do you have to carry the load? How far do you twist? There was one where it was I'm trying to think of what warehouse it was in Pennsylvania. It was either FedEx or UPS. I can't remember which. But the job involved literally picking the package up here, twisting and putting it over here with the deliveries. And every time the person did that, you're just putting all kinds of torque on the spine. Right? That's a repetitive motion. So what if instead of doing that, we can move that belt up here? So we're just going here to here, here to here, and not have to twist. That's going to maybe relieve some of that pain. How far do you reach with the load? And then how long do you sit at your job? Because we know at this point, seated jobs are just about as bad for people as smoking, right? Spending extended periods of time, right? You ideally want to move every hour. So here's what you all came for, right? The McKenzie Method. How many of you guys have heard of the McKenzie Method? Has anyone heard of it? So Anthony says he has, right? Oscar. I figured most of you guys that are in the clinic. What do you guys know about the McKenzie Method?
So I know the technique to do it. Like if you have a posterior bulge in your disc, you do hyperextension to push it back.
Good, right? And that's kind of what we talked about when we talked about the bulging discs, right? It's not only extension. That's the common misconception about McKenzie. It's about directional bias. And what that means is I'm going to go in the direction that I need to go to fix the problem. So if that means side bending to the right, then I'm going to side bend to the right. If that means side bending to the left, side bend to the left. It's pretty rare that we do flexion, but sometimes, right? And Oscar, you're fine. It's just that most people, even most clinicians that practice the McKenzie method just say it's all extension. Yeah and no. A lot of it is extension, and a lot of it's extension because of the concept of how he founded it, right? McKenzie was, I want to say he was in New Zealand. I can't remember if he was New Zealand or Australian. And the interesting story about how he determined McKenzie method is he had a patient coming in with low back pain, and he was working with another patient, and he said to that patient, I'll eval you in a second, go into the room in there and lie down. I'll be right with you. And so she went into the room, and it's one of those old school doctor's plinths, that are kind of angled up. And she went in there and laid on her belly. For whatever reason, she chose to lay on her belly. And he comes in and he says, okay, ma'am, let's sit up and let's talk about it. And she's like, my God, you're a genius. How did you know that was exactly what I needed? And he's like, what? And so then he researched and said, well, extension helped this patient. So maybe there's something here to look into. So with McKenzie, we classify things under either posture symptoms, dysfunction syndromes, or derangement. So posture is problems caused by posture. We correct posture. Dysfunction is where we have either a short or an overly long muscle. So if it's short, we stretch it. If it's too long, we strengthen it. Or derangement, where we have a problem with the disc itself. And at that point, we try to reduce the derangement if we can pull the disc back into its center, or we maintain it so it doesn't get worse so that we can hopefully have some recovery of function. Ideally, the big goal or big thing he brought into play here is centralization, right? This is where we take pain that is peripheralized, move down the legs or move down the arms, and bring it back to the spine where it should be. And distal pain that's immediately or eventually abolished by the application of loading strategies. This is the McKenzie-based method for detection of derangement. So if we are working with the patient and all of a sudden they're like, yeah, my pain's getting better in my butt, but my back's getting worse. Again, we cheer, and that means we're going in the right direction. If I start doing flexion activities and that pain gets worse down my legs and peripheralizes more, then we're going in the wrong direction. We have the wrong directional bias. So when we talk about posture symptoms, right, or syndrome, we're going to look at what the mechanation and the mechanical deformation of the tissue is. What caused it? Do they have hyperlordosis? Do they have kyphosis? Right? Do we have any scoliotic curve going on? And then we're going to encourage the patient, okay, you need to change posture. So if you have a lot of kyphotic posture, you need to do a little bit more lordosis activities, and you need to do that more frequently, right? Maintain lumbar lordosis. Right? That's why having a chair with a good lumbar support pillow back there is good, right? How many of you guys have lumbar pillows or a lumbar support in your car for when you drive long distances? Got one, right? Yeah, and that fancy dancy chair that I have at home from Razor has an active lumbar support in it. So when I actually sit back, it pushes forward and pushes me into lordosis. And it keeps me when I'm leaning back in lordosis. I can do the same thing by putting a little pillow back there too, but that pillow eventually squishes with my body weight. That pretty stiff lordotic curve there actually helps a lot. And I'm amazed at how much it's actually improved my seated posture for most days when I'm not sitting in a crappy chair like this. We're also going to educate the patient and re-instruct them on how to do it. So the golden rule of McKenzie here, and this is one thing I want you guys to learn. If you get nothing out of me talking about this, if your PT is following the McKenzie method and orders you to perform flexion or extension or right side bending or left side bending, you do not change to an alternate motion. So if they're doing a lot of extension, right, you don't suddenly add flexion activities to it until the PT has added that. The directional bias is important. It's important to move towards one direction until the PT has decided we're going to go somewhere else. So if they're doing a lot of right side bending activities, and we determine that, well, maybe we should strengthen up that left QL as well. We're not going to add those left QL activities until the PT has cleared the patient to start doing left side bending again. So we're just going to do whatever that PT says at that point. We are going to stick to it. The key to this is if we have a directional bias into extension that improves the symptoms, if we go the other way, theoretically, that's going to make the symptoms worse, and we're going to regress the therapy we just did. So you want to keep going in the directional bias you're supposed to go. And then the little blurb from the APTA on spinal mobilizations: the scope of the PTA's training is not consistent with demanding working knowledge of neurovascular anatomy, biomechanics, and pathophysiology of lumbar, thoracic, and cervical spine needed to provide mobilization techniques in this area. So what the APTA is basically saying there is, no, 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 not in my house, because there's a house of delegates. Get what I did there? Okay, fine. I thought it was funny. They're basically saying that it's not in the PTA's wheelhouse to do spinal mobs at all, ever. Now, again, could that change down the road? Who knows? But for now, we just go by this, and we do not do spinal mobs, no matter what, period. End of discussion, right? And if you're working with a PT that does McKenzie technique, do we change the direction of motion? Ever. Not unless they tell us. Good. No, no, no. Surprise Dr. Reskin with that next semester, because she's going to re-hit McKenzie technique with you guys again and actually do McKenzie exercises with you. That's good. That's fine. If you get that, that's the most important part about McKenzie, is we don't change techniques. So when you guys go out on your 2-week clinicals and you're working with the patient, you're like, man, I'm running out of extra. I've done all these extension activities within the PT wants. We don't add any more flexion activities until, now, if you're like, hey, could we try these? And the PT is like, hey, sure, go ahead and try crunches with the patient. Okay, the PT has cleared us to do that, right? But if it's all extension activities, we don't add flexion without clearance from the PT first. Phew. That was a long day. Is anyone else fried?
Yep.
I mean, we could go for another 4 hours if people want, but I'm pretty confident that we're done. I'm going to stop the recording right there.